Welcome back to another episode of HealthCap Weekly Wrap. Today we're digging into 5 pieces that honestly feel very connected if you work in senior care right now. We're talking about staffing mandates, labor unions, CMS emergency preparedness expectations, practical regional weather resources, and a very specific life safety code reminder that's easy to underestimate. Oh, and we're going to take our time with these because they deserve more than a quick headline skim.
Yeah, exactly. This isn't one of those episodes where you can just nod along and move on. Each of these has real implications for how senior care communities plan, staff, and invest. So, all right, let's get into it.
We're starting with a Health Affairs article titled State Nursing Home Minimum Staffing Mandates, Increased Staff Levels, Minimal Impact on Finances and Closures, 2010 to 2023. This study looks at more than a decade of data, from 2010 through 2023, and it covers nearly 7,000 senior care communities across 22 states.
Right away, this one challenges a narrative we've all heard for years.
Oh yeah, the idea that staffing mandates are going to financially break communities.
Exactly. And what the authors found is, well, it's more complicated than that. When states implemented or increased minimum staffing mandates, direct care staffing did increase. On average, it went up about 5%. Most of that increase came from licensed practical nurses and certified nursing assistants rather than registered nurses.
And, of course, labor costs went up.
Right, they did. But here's the key point. Those higher labor costs were largely offset by increases in patient revenue. When the authors looked at margins, they didn't see meaningful declines. And when they looked at closures, they didn't see an increase either.
That's huge.
It really is. It doesn't mean mandates are painless. Communities still have to figure out how to hire, schedule, and retain staff in a tight labor market. But this study suggests that staffing mandates alone aren't the financial death sentence they're often portrayed to be. For senior care leaders, that's an important evidence-based reset.
And it also raises the next question, which is, okay, if staffing levels are changing, what does that actually look like inside communities?
Exactly. Which brings us to our second article, also from Health Affairs. This one's titled, The Effects of Labor Unions on Nurse Staffing Ratios and Quality of Care in U.S. Nursing Homes, 2013 to 21. And this is one where, honestly, it's easy to get the takeaway wrong if you're not careful.
Yeah, this is not a unions increased staffing story.
Nope, not at all. What the study shows is that unionization did not change total staffing levels overall. There wasn't an expansion of hours. Instead, there was a shift in the staffing mix. Registered nurse hours decreased, and licensed practical nurse hours increased.
So it's redistribution, not growth.
Exactly. And then there's the quality question, which is what everyone jumps to.
Right. And the authors didn't find evidence that quality of care declined. They also didn't claim big quality improvements. The more accurate takeaway is that quality was maintained despite changes in staffing composition.
Which actually says a lot.
It does. It suggests communities are adapting. Maybe through productivity changes, role redesign, or how teams coordinate care. The study doesn't pin that down completely, but it does show that staffing shifts don't automatically translate into worse outcomes.
When you put this together with the first article, you get a much more realistic picture of staffing today. Policy pressure, labor dynamics, and cost constraints are all interacting at the same time.
Yeah, there's no silver bullet here, just trade-offs and adjustments.
Exactly, and those trade-offs matter even more when we start talking about preparedness and regulation. Which brings us to the third item.
The third piece is CMS guidance on the Emergency Preparedness Rule from Quality, Safety, and Oversight. CMS is very consistent in how it frames this rule, and that consistency is important.
Totally. CMS talks about emergency preparedness in terms of 4 required program components. First, risk assessment and emergency planning. Second, policies and procedures. Third, a communication plan. And fourth, training and testing.
And those are requirements, not suggestions.
Right? These are conditions of participation for Medicare and Medicaid. Surveyors are looking for evidence that these elements exist and that they're functional. CMS isn't asking communities to predict every possible emergency. They're asking for a structured, documented approach that reflects real risks.
And staffing shows up here again.
Oh yeah, you can have the best emergency plan in the world, but if staff don't know their roles or haven't practiced them, it's not going to work. Preparedness lives and dies with the workforce.
Which is why practical tools matter so much. And that leads us to the fourth item, the Great Lakes Region Severe Weather Preparedness Guide from Superior Health Quality Alliance.
I really like this one because it knows what it is.
Yeah, it's not pretending to be CMS guidance.
Exactly. This is a curated resource guide. It focuses on severe weather risks that are especially relevant in the Great Lakes region, like tornadoes, flooding, severe storms, and lingering winter hazards. The goal isn't to create a new framework. It's to save time and reduce information overload.
And you can feel that when you read it.
Absolutely. It brings together reminders, checklists, and links to high-value external tools so communities don't have to reinvent the wheel. It supports planning and response efforts without adding another layer of regulatory complexity.
For senior care leaders, this is the kind of resource that helps bridge the gap between CMS expectations and real-world execution.
And then we wrap up with the most targeted and concrete item of the 5.
Right. The CMS Quality, Safety and Oversight Special Alert Memorandum, QSO 2602 ALL.
This one's all about life safety code compliance, specifically automatic sprinkler systems.
Yes. CMS is reminding Medicare and Medicaid certified providers that if a community is classified as an existing healthcare occupancy in a high-rise building, it must have approved supervised automatic sprinkler systems installed throughout the building by July 5, 2028, in accordance with the 2012 NFPA Life Safety Code.
And just to be clear, this isn't a new requirement.
Correct. This memo reinforces existing obligations. What CMS really emphasizes is early planning. Sprinkler installation takes time, it's expensive, it's complex. Waiting too long can create serious challenges.
This is one of those reminders that compliance isn't just about policies and binders.
Exactly. It's about infrastructure, capital planning, and long-term decision-making.
When you look at all 5 pieces together, there's a clear arc. Staffing mandates shape expectations. Labor dynamics shape how teams respond. CMS defines preparedness requirements. Regional tools help communities act on them. And specific compliance reminders highlight where long-term planning really matters.
For senior care leaders, the takeaway isn't panic. It's clarity. Knowing what's evidence-based, what's required, and what's supportive helps communities focus their energy where it counts.
All right, that's where we'll leave it for today. Thanks so much for spending time with us on HealthCap Weekly Wrap. And if you're looking for more insights like these, be sure to check out Angie's blog at healthcapusa.com/Angie's-blog. We'll see you next time.